Good morning or good afternoon. This is Steven Opal, and I'm introducing the panel who will be speaking today at our symposium. I'm an infectious disease physician from Providence, Rhode Island. We have an internationally famous group here today, and we're going to go ahead and get started. And just make a few general comments to begin with. First of all, we who are dealing with critically ill patients in the intensive care unit are still struggling with having accurate diagnoses of infection. And many times it's very difficult for us at the bedside to determine who's got a systemic inflammatory response that's not due to a microorganism versus one that is due to a microorganism. And this has been a problem for a very long time. It continues to be a problem. And it is an interesting and hopeful situation that we see a drug like pancreatic stone protein making it into clinical development. It's a very interesting molecule that's potentially going to serve us well in helping with distinguishing non-infectious febrile illnesses in the intensive care unit versus infectious. So we hope to enlighten the group who's tuned in today as to where things stand with this idea and how it fits in with our therapeutic armamentarium in the future. So I'm going to introduce our first speaker now, who is a man who needs no introduction. Bruno François from Loge, France, has been a major contributor to the study of sepsis for many years. And he is going to start us off with a discussion about the serial point of care measurement of pancreatic stone protein in critically ill. So, Dr. François.
Yes, thanks a lot, Steve. Hello, everybody. Good morning, good afternoon. I'm very happy to present you the result from recently ended trial with that we have done with some European colleague. I'm a critical care physician working at Limoges, France. Of nowhere, 400 kilometers below Paris. So before entering the trial, oh, sorry. Can you help Romy with the presentation? Next slide. I've got a true transparency declaration. I'm collaborating with a few pharmaceutical companies. They are listed on the slide. Next slide, please, Romy. So for those of you who are not completely comfortable with PSP, PSP is an interesting biomarker. It's a 16 kilodalton polypeptide from the lectin family, and it's mostly involved in the immune response. It's mostly, PSP is mostly secreted by the pancreas, but also by the intestine and the stomach, and it's a sort of early sensor of sepsis and multi-organ dysfunction, which act as a alert signal. So it's a pretty interesting biomarker for sepsis. And then it binds with neutrophil, but is also acting in the response in the polymorphonuclear cells. So it's a pretty interesting biomarker for infection in general and sepsis. Next slide, please. So a lot has been published about PSP, and in order to introduce our recent trial, I will go briefly through a few trials recently ended. This one published few years ago, demonstrating an interesting correlation of PSP to diagnose sepsis at ICU admission. It was a single center observational study, but the sample size is pretty impressive, to more than 200 patients. Within 6 hours of admission in the ICU or high dependency care unit, the PSP was sampled, and then thanks to an adjudication committee, the patient was categorized in 2 different subpopulations, either sepsis or inflammatory syndrome, SIRS, which is not anymore available, but SIRS of non-infective etiology. And within all the biomarkers that were tested, including PCT, IL-6, but also IL-8, the PSP showed the highest diagnostic accuracy among all the biomarkers and the highest NPV. And interestingly, PSP was also correlating with the severity illness, not only in the non-infective SIRS, but more interestingly in the sepsis population, severity being evaluated by the SOFA score, and with a nice correlation. This is another interesting trial in cardiac surgery. Again, single center prospective observational study on more than 140 unselected patients that underwent elective cardiac surgery, and both CRP and PSP was sampled on the day prior to the surgery, and then once a day for the 3 following day, and in order to predict the onset of a postoperative infection. And again, as you may see on the left-hand side, there is a nice difference between, even if there is an overlap, which is pretty classical with biomarker, but there is an interesting difference between non-infected patient, which is the white bar, and the infected patient, which is the gray bar, which is not what has been found with the CRP. And in terms of ROC curve, the accuracy is much better with the PSP than the CRP. And one other interesting trial, which is evaluating the interest of the PSP at time of admission in the emergency department. Again, it's an observational prospective single center study in Spain, roughly 130 patients, and when compared to the classical other biomarker, including PCT, which is the most popular, the PSP has similar performance than PCT at admission at the emergency department, to make a difference between those who were only infected and those with sepsis. So from more than 10 trials, more than 10 studies, including more than 1,000 patients, PSP seems an interesting biomarker, not only to diagnose sepsis, but also to predict infection, not only in medical population, but also in the surgical population. So according to this interest, this capacity, but also considering the biggest current challenge with sepsis patients, which remain the early diagnosis, as mentioned by not only the Surviving Sepsis campaign, but also WHO and the NICE. The biggest issue is to early recognize sepsis, and in order to timely document and also treat the patient. So this is why, with some other colleagues, we have designed and realized the AB-PSP 001 trial. So this is a trial recently ended, run at 14 sites in 4 different countries: Switzerland, France, Italy, and UK. The primary objective was to assess the performance of serial PSP value measured at the bedside using the Abioscope, which is a point of care, giving the PSP evaluation within 5 minutes with only a blood drop of 20 microliter, and it's based on nanofluidic technology. Inclusion-exclusion criteria were the following. So we have included adult patients admitted to the ICU at risk of sepsis, but without any ongoing sepsis. Those with ongoing sepsis were excluded. In order to have sufficient nosocomial sepsis, we intend to enroll patients expected to stay in the ICU for at least 7 days and on mechanical ventilation for 5 days, and written consent. The patient which were considered as moribund were excluded. Patients that had received antibiotic treatment outside antibiotic prophylaxis were excluded. Chronic patient with chronic disease with or any medical history making assessments and were excluded, and patient in which the PSP could have been abnormally high, such as chronic pancreatitis or pancreatic cancer, were also excluded. In terms of trial procedure, patients were managed according to the local SOP, completely left to the investigator. Patients were followed until death or discharge from the ICU, or for 30 days, whichever occurred first. And for the sepsis diagnosis, the sepsis 3 definition was used. The 3 different biomarkers were daily assessed, not only PSP, thanks to the point of care Abioscope system, but also the CRP and the PCT centrally measured. And a blinded adjudication committee was responsible for the adjudication of all sepsis events. It was composed from with 3 ICU experts. 2 were non-chair and independently reviewed the cases. And in case of disagreement, the chair was responsible for the final decision, and they were responsible to confirm any sepsis event based on all information available, including biological information that were available as part of standard of care. Some sites were already using CRP and PCT, which can introduce somewhere of bias, but which was not the most frequent case. And they were also responsible, in addition to the diagnostic of sepsis, to confirm the date of event. Roughly 300 patients has been screened. A few of them were excluded before evaluation by the adjudication committee, mostly because not staying enough longer in the ICU. 276 patients were evaluated by the adjudication committee. 33 were excluded because of an ongoing infection, according to all information available. And finally, 243 patients were analyze. These are the characteristics, which are pretty classical. Year of age, no major difference in terms of type of population. A predominance of neuro patients, which is pretty classical according to the fact that we were getting a population likely to stay at least 7 days in the ICU. Nearly 80% were receiving mechanical ventilation, and roughly 40% were receiving vasopressor. The length of stay in the ICU was much longer in the sepsis population, which is not very surprising. For the 21% of the entire population developed sepsis, according to the evaluation committee, there was a discrepancy of between the two adjudicators of 31%, which has been arbitrated by the chair of the evaluation committee. These are the characteristic of the patient, and most of the nosocomial sepsis was driven by the pulmonary infection, which is again not very surprising. This is probably one of the most interesting piece of the trial. Area under the ROC curve on the day of sepsis, which was blindly adjudicated by the adjudication committee, was similar for all three biomarkers. PSP has the greatest sensitivity and CRP with the greatest specificity. And when combining both PSP and CRP, it improved accuracy for sepsis diagnosis. But the addition of PCT did not bring any improvement in terms of accuracy and sensitivity. And this is probably one of the most interesting findings. So not only considering the PSP as a unique biomarker at one specific time point, but more looking at the evolution and the trend in the evolution of both the PSP, the PCT, and the CRP. And as you may see, the best prediction is given by the PSP as illustrated on the left hand side of the slide. The red curve being the sepsis population, and the blue one being the non-sepsis population. For both PCT and CRP, there is a cross between the two. And what you can see, the right side of the every figure being the timing of the sepsis, the day 0 of the sepsis. And as you may see, there is a nice trend of increase of the PSP prior to the onset of sepsis. So when considering this evolution, to say it differently, the evolution, the progression of the PSP 3 days preceding the true onset of sepsis is a really good predictor of the onset of this event. Our study has several limitations. First of all, there are differences as classically between the study sites. And although the expected number of patients who develop sepsis was reached, the low absolute number of sepsis events precludes subgroup analysis by site or country, because it's remained a small trial. And of course, we have selected a subgroup of population which can be slightly different than a classical ICU population. And this we cannot this time extend our finding to a classical ICU population. So to conclude, blood PSP sample at the bedside, thanks to a point-of-care system, increased incrementally 3 days before the clinical diagnosis of nosocomial sepsis when diagnosed by an independent adjudication committee. And the association of PSP and PSP evolution is stronger than for PCT and CRP, which are classically used in the ICU to predict onset of sepsis. And this result probably justify further evaluation on the clinical benefit of the serial PSP measurement through an impact trial. Thanks a lot. And again, thanks to all my colleagues that are participating to the trial.
Thanks, Bruno. That was a superb talk. I wanted to mention to the listening audience that we are going to have opportunity for a question and answer, but we decided to wait until the end to do them all together. So if you have ideas or questions you want to ask, jot them down, and we will get to them at the end when all three presentations have been given. So thanks, Bruno. That was superb. We're now going to move on and have Angelo Giacomucci from Italy give us the presentation, which would be real-life implementation of PSP testing in a clinical setting. Angelo.
Thank you. Good afternoon. I'm Angelo Giacomucci from Perugia, Italy. And I'm speaking about real-life implementation of PSP testing in a clinical setting. These are my disclosures. And just as it's a real-life presentation, this is the place where I live as a medieval science in central Italy. And this is the hospital where we work. It's a 850-bed university hospital with 13-bed ICU. And can I have the next slide, please? So we all know that as the time course of sepsis spans from early signs of infection to the later signs of septic shock and multiple organ failure, it is crucial for an early diagnosis to have early biomarkers available, and this is outlined in this slide. So, but this is a list that is not definitively a list of the biomarker that we have at the moment available. So the question is, do we really need to add another biomarker to this plethora? Probably the answer is in the statement from this paper by Tony Torres, and the expressions highlighted is are the key to the answer. So PSP, Bruno François already talked about the biological and clinical characteristics of PSP, and also showed the results of earlier clinical studies. And so I'm not talking about them again, but a few words about the PSP 001, which is a multi-center study, which Bruno François already talked about, to which we contributed with 20 patients. These are the characteristics of the patients from our sites. In the diagram on the left, the sources of sepsis are outlined, and here are the microorganisms isolated. And these are the results from just from the patient from our sites, and it's our results are fully consistent with the global results of the study. According to these results, PSP can be considered not only as a early marker of sepsis, but also as a predictor of sepsis. How to turn knowledge into practice? And we try to implement the use of PSP in our ICU, and we started by severely measuring PSP in by now up to 50 patients that were admitted to our ICU in the last months. We used the point of care technology. This is the point of care device we used, And this is the core of the technology. It allows a very small amount of blood to be drawn from the patient, and just 30 microliters of blood are necessary for the test. The patient's blood is then mixed with reaction solution, and these 30 microliters of this mix is then spilled inside the capsule. And this is what happens inside the capsule, where PSP molecules are bound to fluorescein-labeled antibodies, and the antibody PSP complex is then captured inside the nanochannel by this capture molecule that is spread on the inner sides of the microchannel, the nanochannel. And the resulting fluorescence is then measured by a laser detector. And the results are then displayed in terms of PSP concentration. And there's also a further potential role because in each capsule there are 14 channels, and potentially it will allow the measurement of 14 different biomarkers with just one shot. So this makes the device easy to use and suitable for routine use as much as is the blood gas analyzer, for example. This is a picture from our ICU where the device is actually on the same bench as the blood gas analyzer. Also, one more characteristic of this device is its connectivity. So it can be connected to the hospital network. And so data can be directly transferred to the digital records of the patients. And also a QR code can be generated to transfer data to a smartphone with an app. So we have a little bit of clinical scenarios. This is a woman, 48-year-old woman. She was admitted to our ICU because of sepsis from urinary tract infection. And in this patient, the levels of PSP remain constantly elevated until the patient died from multiple organ failure. And we can assume that in this patient, the elevated levels of PSP were predictor of death. Is not the case for procalcitonin, for example, that was level decreased during the first days. This is another patient. He's a 79-year-old man. He was admitted for acute respiratory failure due to suspected community-acquired pneumonia, and antibiotics were started at admission. But the PSP levels remain constantly below the cutoff level, and then antibiotics were de-escalated, and the patient responded to steroids until the patient was discharged with diagnosis of perineuroplastic syndrome. So in this patient, PSP could rule out. In this patient, PSP could rule out a diagnosis of infection and sepsis. COVID-19 patients are a particular subset of patients. This is a 29-year-old patient. He was admitted for acute respiratory failure due to COVID-19 pneumonia. And also in this patient, empirical antibiotic treatment was started at admission, but after a transient increase, the levels of PSP decreased, and also antibiotics were de-escalated until the patient could be transferred to a pulmonary care ward. This is another COVID-19 patient in a 64-year-old woman. She was admitted for acute respiratory failure due to COVID-19 pneumonia, and in these patients, the level of PSP started to rise after a few days from the admission, and 2 days before, 2 days later, the clinical condition worsened, and noradrenaline had to be started. Days later, the PSP levels decreased, and at the same time, we could decrease the rate of infusion of noradrenaline. So in this case, PSP was reflected the clinical course of the patient, and also the rate of noradrenaline infusion. But eventually, the patient died for the complication of COVID pneumonia. So how can we conclude? PSP in the clinical setting, PSP promises to be an early marker of sepsis, not only, but also a predictor of sepsis and a predictor of death in patient with sepsis. And its time course tends to be correlated with the clinical course and even with the catecholamine infusion rate. All this combines with the advantages of a point of care technology. So what in the future we can expect for the changes in management, possibly improvement in management that might lead eventually to better clinical outcomes and better survivals. One more consideration. Normally around an ICU bed there are a number of point of care devices, let alone the blood gas analyzer, but we also have, for example, ROTAM or point of care ultrasound, which is becoming more and more whole body ultrasound. And also we have point of care devices for neurologic assessment, and we have calorimetry for assessment of the metabolic state of the patient, and point of care devices for determination of the early markers of kidney disease. So the availability of a point of care device for the detection of markers of sepsis is an added value to our armamentary in the ICU. And also it's a step forward so that precision medicine, as it's defined in this review by Jean-Louis Vincent, that we, as ICU doctors, and also in other specialties, are going to face more and more in the years to come. I have a last slide just to acknowledge all the people who have been implementation of PSP determinations in our ICU, and I'm quite confident that most of them are now attending the webinar. Thank you.
Excellent. Thank you very much. It's a beautiful study and really nice work. And the interplay between PSP and other markers is going to be critical to develop the technology and expertise with it. It's very, very nicely done. Thank you, Angelo, very much.
Thank you.
We're now going to move on to the final presentation, and this will be given by Philippe Eggiman from Switzerland. And the topic is PSP as a septic biomarker, a meta-analysis. So Philippe.
Thank you. Hello, everybody. I'm very happy that you are able to attend this webinar. I will speak you from PSP as a septic biomarker because we recently performed a meta-analysis of some published studies, and I will share with you the results which are currently submitted for publication. So first, sorry, it's very sensitive. So first, be careful, because anything I say can be biased by all the relationship I have with the industry. I collaborated to several clinical trials, and I regularly serve and on advisory boards and consultant for many companies. But you will be reassured because I have no offshore accounts. I'm working in a public hospital, and all honoraries has to go on a hospital account, and we can only pay for research nurses and data manager, like for the statistical analysis I will present you. And you will be able to judge at the end of the presentation if I'm really biased or not. So sepsis, you know, it's a worldwide problem with several millions of cases every year, and with a small decreasing mortality, but representing around 20% of all global deaths around the world. And you know that it's even worse in the ICU, where the recent EPIC-3 study just published last week showed that about 2/3 of patients requiring ICU management have an infection, and the majority of them are nosocomial infections, so nosocomial acquired during the care for something else in our ICUs. Sepsis biomarker is a whole world of investigation, and you know that we have tens, I should say hundreds of biomarkers described. They are regularly reviewed, like here in this recent review from our colleagues Priakos and Jean-Louis Vincent. And we should realize that except only few like lactate, CRP and procalcitonin, virtually none other are currently used at the bedsides to try to guide our management of patients with sepsis. I will not go in detail again on PSP because Bruno François has explained to you that this was a protein secreted initially by the pancreas, but it's important that probably it may be secreted as a response to stress, particularly when the stress is an infection. And the first clinical description in the field of sepsis was made 10 years ago by this group of Zurich, with the unique fact that in these multiple trauma patients, the rise of pancreatic stone protein precedes the development of an infectious complication for a few days, and this opened the way for new things. And I will not go on details on these studies because they have been partially presented by Bruno François, and I will just go now in this meta-analysis. We performed an individual patient level meta-analysis. It significates that we get access to all individual data of the patient included here in these 5 studies dealing with the value of PSP as a biomarker to diagnose infection. Here you have the characteristics of these patients, and you can see that in all these studies, the authors compared the pancreatic stone protein with the CRP and the procalcitonin in patients with and without infection. The setting was patient in the ICU, or for one study or 2 studies, sorry, patients coming in the emergency room with suspicion of infection. And here, as a graph is better than text, you can see the distribution on this panel here of the pancreatic stone protein in patients with and without infection in these 5 studies, compared here to the value of the procalcitonin, and on the right to the value of the C-reactive protein. And to summarize that, here you have the value showing that the PSP are very different in patients with infection compared to patients without infection. It was also true for procalcitonin and for C-reactive protein, but please note that the value of the CRP in non-infected patients was quite high, 78. This is quite high for this patient. And in the first interesting observation is here when we plot all these cases. The spot in reds are the patients with an infection, and the black are those patients without an infection. And you can see from these figures that the overlap between patients developing an infection in red and those without infection in black is less important for pancreatic stone protein compared to CRP and even to procalcitonin, where the overlap is much higher. Interestingly, this translates here in the accuracy of PSP to procalcitonin and CRP to diagnose infection in these patients. This is to show the individual AUC value of all these 5 studies, and put together here, you can see that when using a methodological approach with the Uden index approach, we were able to determine for pancreatic stone protein a cutoff value of 44 nanogram per milliliter with an AUC value of 0.8, which was a little bit higher than the AUC of CRP and the AUC of PCT. Interestingly, here the cutoff of CRP is much higher than could be expected for patients with and without infection. And here the cutoff value we found for PCT is lower than the 0.5 currently used in the clinical setting. And it's interesting here to see that when we combine the value of the PSP with the CRP, this further increase the AUC value of 10%, and we reach 0.9% with a positive likelihood ratio about 5 and a negative likelihood ratio of 0.2. So this could be interesting, because you may know that the Abionic, the firma who developed the point-of-care PSP measurement chip, has decided to put on the same cartridge both determination of PSP and CRP. So these 2 values may be available in the next future for point-of-care determination. So in conclusion to this meta-analysis designed to explore the diagnostic accuracy of infection in patients of the PSP compared to PCT and CRP in an individual patient meta-analysis, we conclude from this meta-analysis that PSP is a promising biomarker to detect infection with a cutoff value which is quite low, without huge overlap compared to CRP and PSP, that it is probably a valuable biomarker, and that the combination of PSP with CRP may add something to reach very interesting predictive value to detect an infection. And this is only at time where the infection was diagnosed. This is not what has Bruno showed to you. We did not explore the potential of predicting the development of an infection. So I thank you for your attention, and please take care, because we are all currently dealing with many COVID patients.
Thanks, Philippe. That was really superb, and the data is very impressive. It's nicely done, and an individual patient analysis is really first rate. So thank you very much. We're now open to question and answers from the audience, if there are any. And let me just start with the question for Philippe then. So the nature of the pathogen doesn't seem to have much impact on the data, as I understand it. So viruses, gram-negative bacteria, gram-positive bacteria, fungi, Is there any situation with pancreatic stone protein that the nature of the organism is critical?
No, thank you for this question. It seems that the pancreatic stone protein does not increase a lot in fungal infections and in viral infections. And in the study and in the individual patient data meta-analysis, these were all documented bacterial infections.
Okay. So, Angel, some of the data that you showed was from COVID patients, and I was impressed that you could measure that, or you could determine with the PSP, you could show that are we assuming that what you're measuring in that situation is the virus, or is it secondary bacterial infections that you can find checking for that assay?
Oh, I think I can be quite confident that if we have a real rise in PSP, it's due to a bacterial superinfection. In most of our COVID-19 patients, the PSP levels tended to be constantly low. Only in a few fraction, in a few number of our COVID-19 patients, we have a rise in PSP levels. And in those patients, almost every time we had a bacterial isolate.
Okay, excellent. Thanks very much. We have a question from the audience. Has anyone looked at delta values? It might be that the AUC would be even higher. So is that worthwhile? Philippe, what do you think, to look at the data, or the delta value is from start to finish, and use that as a guidepost?
I think it's very interesting. It should be put on the agenda for further studies to see if, as for lactate evolution, for example, in patients with infection or with sepsis, it may add some value compared to the absolute value of the biomarker, for sure. And we could probably take advantage, as Bruno presented here, to realize or to perform serial measurement of this biomarker. It's on a chip. It's very simple to determine. You can do that on waste of blood you draw for blood gas analysis, for example. It could be at the bedside, and probably for a price which will be comparable to the protein C-reactive. So I think it's a new era to explore. It's to take into account the dynamic of the evolution of the biomarker.
Great. Excellent. Other questions? Perhaps the panelists as well could feel free to ask a question. Let me just, yes.
Yeah, maybe just a comment about the trends.
Please.
Usually, as clinician, what we like is to have a value, a cutoff, and say yes or no. And I'm not completely sure that this is how it works, because usually when a patient is getting worse, we have a lot of different finding clinical vital sign and things that are going worse. A lot hypertension, tachycardia, marbling, and so on. Maybe what the interest of what we found in the trial and the concept of serial measurement is to detect something which is a silent disease, in fact. And you cannot define a cutoff. And I know as a clinician, it's not easy because when you are doing some teaching or to explaining to the younger physicians, the fellows, people need to have something like 5, 10, above, below, and that's it. And what is interesting and is the figures that I have presented is the trend, the continuation, the increase incrementally, and this should sort of work as an alert at the bedside. And I think the next trial should be such as an impact trial on whether or not, when detecting something which is increasing, starting prior to the onset of something, already antibiotics or some other things. So we have to change a little bit the paradigm between cutoff value, something which is really strict, and more interpreting trends. And it's new, but probably in the coming years, I can see that working at the bedside thanks to this point of care machine or other type of biomarker. I don't know if you would agree with that, Philippe.
Yeah, fully agree. I think we should change something. We should have something to take into account the dynamic. When you make the round of when you see the patient, you see the face of the nurse who has spent the night with the patients. You have some few information, and you have the suspicion that something is going wrong. And maybe repetitive measurement of a very easy, a simple parameter like PSP could be like you, as you say, a signal, an alert that something may probably will probably go wrong. And in this patient, you will probably take a special attention on it. You will not transfer it. You will maybe order some other investigation. And I think that it will be viewed as a triage value, and you can document that you're feeling that something is going wrong, maybe based on some biological signal.
Okay. Good point.
Yeah, what is key, I think it's, and this is probably the challenge for the concept, and the challenge for the abioscope and the PSP is to compare these trends of PSP to other silent biomarkers. Can be lymphopenia, can be urea, can be a lot of things, because with some experience we can also see something, and this is exactly what we have to now to document.
An interesting point to go in that direction is that in many studies, PSP has an initial prognostic value about the outcome many days later, and maybe we can try to find a way to take advantage of this possibility.
Right, absolutely. And we've been trying for a long time to come up with early, rapid diagnostic information that could assist us in decision making, and I think this is getting closer to that end. So nicely put. Are there other questions for the panel? I should point out that I don't know if you've received this or not, but there's a brief questionnaire of critical issues that you'd like to see dealt with and symposia about. So for the audience, if you could fill that form out, that would be very helpful. And are there? Yeah. So here's the poll that you're being asked. So if you're a medical doctor, what are the main challenges you encounter with sepsis today? And please go ahead and fill that out and give us some idea of where you think we should be going. And let me just thank the panelists. The presentations were superb, and we really appreciated the efforts you put into this this symposium. So at this point, unless there's some other items that should be dealt with, I think we're adjourned. And I want to thank everyone once again for your assistance. Thanks very much.
Thank you. Thank you.
Thank
Bye.
you.
Thank you.